So we're good to go.
Hello, everyone. Welcome to the April month episode of Academy of Bronchoscopy webinar. And last month we have covered the postgraduate courses. This time we have a special topic that is management of bronchopleural fistula by bronchoscopy. And as we know, bronchopleural fistula management is not uniform because there is no uniform guidelines on how we manage these cases. So we invited a special guest today, Professor Grigoris Stratakos from Greece, who is a very active intervention pulmonologist from Europe, and he will be discussing on different aspects of bronchoscopy and management of bronchopleural fistulas with a special focus on silver nitrate application because he has done extensive research on silver nitrate application in post bronchoscope, post BPF cases. And we know there are a lot of etiologies, especially for those from the European part who are listening. Though the literature says the post BPF incidence etiology is high in post surgical cases, that's the most common, I think. But in India, we have a lot of tuberculosis related bronchopleural fistulas that we see because of the necrotizing infection that happens in TB. And also, many a times, students who are watching this webinar, you have air leaks after ICD placements or when you do thoracentesis, or sometimes a difficult intubation when the bougie is passed roughly. And sometimes we also see BPF happening in patients who have NG tube malposition. So there are different etiologies for this bronchopleural fistulas. And I invite Professor Grigoris Stratakos. He's a professor of respiratory medicine and intervention pulmonology at the National and Kapodistrian University of Athens. And he heads the intervention pulmonary unit, and he's also past president for European Association of Bronchology and Intervention Pulmonology. Recently, we met in Istanbul, and then he was sharing his experience with me on BPF closure. And then I thought, why not we take it to our webinar and then educate the students who are watching this. Dear Professor, welcome to Academy of Bronchoscopy, and we are really thankful for sparing your Sunday on this for this lecture. You can start the lecture now.
Thank you very much, Harry. Welcome to all our participants and the audience tonight. And I'm really glad and humbled for this introduction and the invitation. I will just try to share my presentation right now. And okay, and I hope you're able to see the slideshow. Is it visible?
Yes.
Okay, great. Okay, so thank you for this introduction, and I will also start by explaining before explaining the management, the treatment of bronchopleural fistula. I think it's nice to understand better what is a bronchopleural fistula and how many different types and characteristics this communication might have. So we're talking of an airway to pleural space communication, and of course this might be either central in the central airways, which are visible with bronchoscopy, and in that case is mostly after surgery, especially after pneumonectomy. There might be dehiscence or a gap in the stump after pneumonectomy. But as you very nicely noticed, Harry, that could also be in the peripheral airways, and in that case, the site of the communication is not visible, and we might have a leak from there, an air leak, which is located in the distal airways or in the visceral pleural surface of the lung. Of course, the problem with this communication is that we have a communication from the non-sterile environment of the airways to the sterile pleural cavity environment, and that can be potentially fatal. It is critical then to identify soon and treat this communication the best way possible to avoid any complications, either infectious or mechanical, from the lung. what can cause this kind of communications and fistulas? Of course, as you said, in the Western world, mostly it is a postoperative complication, and it is reported in a very big range of um, of percentages after pulmonary resection. It is more common after pneumonectomy. It can be something between 4.5 to 20% after pneumonectomy, especially on the right side, and very rare after lobectomy. The technical characteristics of the patients who most often develop this kind of communication is the right side of the pneumonectomy, the long bronchial stump. This is something which is a surgical fault and might increase the risk for a bronchopleural fistula after surgery if the surgeon leaves a big stump of the right main bronchus after the resection. And of course, the extended lymphadenectomy can result in devascularization of the bronchial stump and thus necrosis and then dehiscence of the stump. The intense inflammation or infection of the patient before the surgery, the extensive use of steroids, diabetes mellitus also, and malnutrition, and the chemoradiotherapy in neoadjuvant setting, that is before surgery, can also increase the potential of developing a bronchopleural fistula after surgery. Lung cancer, especially in the airways or the mediastinum, can also cause rupture of the bronchial wall and lead to bronchopleural communication fistulas. But as you said, in countries like India or China or even Russia, we have reports of necrotizing lung infection either from TB or other pathogens or fungal or abscesses of common pathogens that can create bronchopleural fistula, especially in the periphery. Of course, chest trauma can do the same, and sometimes spontaneous pneumothorax, even in the primary spontaneous pneumothorax setting, when having a continuous air leak more than 72 hours, that can also mean that there is a bronchopleural fistula in the periphery, which is developed. And of course, barotrauma in the ICU. Okay, how this clinical entity is presented. Of course, there is some difference between acute and subacute presentation. In the acute presentation, which is the most common, we see flooding of the airways from the pleural fluid, which has been accumulated after surgery, and there is intense cough and flooding of the pleural fluid which comes into the airways, and that can be life-threatening. We can have emphysema, subcutaneous emphysema, and of course, expectoration of purulent materials. The most striking feature of the chest X-ray is the changing air fluid level in the chest X-ray, because we can see it here. For example, you see this air fluid level, which is here. It was a few centimeters above a few days ago, and now the fluid has gone down because it has been expectorated through the bronchopleural fistula. So this is one of the characteristic images on the chest X-ray. The mortality is high, and even in recent series, it's something like 25 to 27%, which is of course very high after surgery. Now, as for the subacute presentation, it is usually associated with infectious process, like you said, tuberculosis or fungal infections. This can be insidious clinical course with wasting, with malaise and weight loss, fever, not very high grade fever, cough, and of course, productive purulent sputum, productive cough with purulent sputum, expectoration. How come we confirm the diagnosis? The CT can be helpful. Like we said, the new air fluid level post-pneumonectomy is very characteristic, or the disappearance of the fluid which was accumulated before. We can instill methylene blue from the airways, and then we detect it in the chest tube, and which is also a proof of the communication. And of course, the CT is useful. It can localize and detect the etiology of the BPF in at least half of the cases. But the most helpful modality to diagnose this communication is, of course, bronchoscopy, with two ways, either with direct visualization of the central airway communication, like in these two images. As you see, there is a central gap of the stump. You can see these two different cases, and there is a dehiscence of the stump. There's a rupture of the suture line, and then, of course, we localize the central bronchopleural fistula. In cases of peripheral fistula, where we don't see anything in the central airways, we can localize the position of the site of the leak by inflating a balloon, a bronchial blocker, in each of the segmental bronchi orifices that we see in the diseased lung. So we inflate the balloon at each one of the segments, and then we see when the air leak stops. If the air leak stops after occluding a very specific orifice of a segmental bronchus, we know that the leak comes from that segment of the lung, and then we can schedule the treatment and the management of this air leak. So this is the two ways. These are the two ways with which bronchoscopy can localize and confirm the bronchopleural fistula, either in central airways or in the periphery. As for the prognosis and management, the size of the defect and the timing of the bronchopleural fistula presentation are critical. When you have early bronchopleural fistula presentation and large bronchial defects in the central airways, these are mostly due to technical faults or massive ischemic bronchial necrosis, such as we see in lung transplantation, for example. And of course, this represents a life-threatening condition, especially after pneumonectomy. These conditions, they often require an extensive surgical intervention, and there are difficulties for resuturing due to the tissue frailty. So it's a very life-threatening, difficult case to treat, and it's mostly surgical indication with reoperation, rethoracotomy, and extensive surgical interventions. As for the intermediate, which is between 1 week and 1 month, or the late after 1 month presentation of BPF, and when these are small, especially in the central airways, these are better tolerated. They have more insidious clinical presentation, and a conservative and bronchoscopic treatment could be considered in these cases as an alternative to surgical reexploration. So in this presentation, we will mostly deal with these intermediate and late presentation of BPFs and the small size, which means something between 3, 5, 6 millimeters and 1 or 1.5 centimeters, up to 1.5 centimeters. Larger defects and larger communications are more difficult to treat with bronchoscopy, but we will see some exceptions to that. Okay, what are the available treatment options? As we said, we have the surgical procedures, which are transsternal mediastinal closure of the BPF, radiothoracotomy, thoracoscopy, chest wall fenestration, debridement and closure with buttressing of the pedicle nomental or muscle flap on one side. On the other side, we have some conservative bronchoscopic techniques. In all cases, the mortality is high and the effectiveness is low, and that we have to remember, and we have to discuss that with the patient and the colleagues who refer us the patients. That is an interesting meta-analysis of 85 post-pneumonectomy bronchopleural fistulas, which was published several years ago, and they addressed effectiveness of bronchoscopic treatment as compared with surgery. And I refer to that, although it is relatively old publication, just because it was very methodological in the ways it presented the available options. And I will use this methodological classification of the available options. First of all, mortalities, again, for the second time, I say that it's high, and there's a very low reported cure rate which is at the level of 30%. We have three categories of management, of options. The first was stenting, just putting a plug or a stent to obstruct the communication. And that is mostly used for larger BPFs above 5 or 6 millimeters in the central airways, of course. And why stents have been used: self-expandable metallic stents, spigots, autonomy spigots, lead plugs, and any other things you can imagine. And of course, the valves we use for the lung volume reduction, emphasis, inspiration alike, and the unplugged device, which is for the heart septum. The second idea, the second category of modalities is occlusion of the gap with chemical or biological sealants. And that is mostly useful for the peripheral bronchopleural fistulas, just like we discussed for tuberculosis or for fungal infections or for peripheral lung defects. And that includes bioglue, kinocrylate glue, gel foam, autologous blood, and stem cells, and other techniques. So putting a stent in front, in the central, occluding with a chemical or biological sealant the periphery. And the third idea, the third route, the third way of approaching this problem is to induce scar formation, scar tissue, or granuloma formation after irritating the mucosa. That's the third idea. So how come we could produce this kind of scar formation and granuloma formation? By irritating with laser the mucosa, by injecting submucosally either polidocanol, which is a vein sclerosant, or alcohol, pure alcohol, or producing a chemical burn with silver nitrate, which all these techniques of the third approach have a considerable success rate and very few complications. So this is a nice idea. We will refer to each one of these ideas and approaches in detail just in a few moments. Let's start with the stenting. Okay, this is a report by Henry Colt, which is also included in his very interesting book, Central Airways Disorders, and he classifies the types of stent we can use for the central defects of the bronchial stump. You can see here in the first row, we can use a customized Y stent like this one. If this is for a right pneumonectomy central BPF, and he has customized this Y stent by putting this blocker in the right stump, in the right bronchus stem of the stent, and from the pleural space he has sutured this blocker there, so the communication stops. This is the first idea with a silicone Y stent. This is an expandable metal stent, like in this case you see in the left corner, in the right down corner, you can see this stent placement, self-expandable, which goes from the left main, which is the functioning lung, to the trachea, and thus occludes the opening of the right orifice, which is the problematic one. We can just put a stent closed in the right main, or just put an unplugged device, which I will explain what it is in a moment. So stenting might be useful in these big, large central airway fistulas, which cannot be reoperated, or in which surgeons have excluded any further surgical approach. And of course, they're very interesting. You can find them all in this very, very nice book of Henry Colt and Septimium work. This is the unplugged device. There are several reports in the literature, many years now, for using this unplugged device, which are two discs connected within with a central axis, and which is designed for closing the defects of the heart septum. And they can be introduced by the scope with this introducer catheter, you can pass through the communication, deploy the first part of the disc of the implanter in the pleural cavity, and then bring back a little bit the stent and deploy the rest of the disc of the implanter in the bronchial cavity, in the bronchial space. So there are the two discs of the implanters are deployed, one in the pleural and one in the bronchial space, and thus the communication is occluded. It's a very useful and very effective way of treating large necrotic fistulas of the central airways, especially the right main, but be cautious, especially when the fistula is located near a major vascular structure, and especially when there's a presence of necrosis in the airway, and that can cause severe and massive bleeding, of course. You can see here some cases. We have also treated a few patients with this device when there was no other option to use, and it worked in the ICU. We were able to wean patients from mechanical ventilation by this technique. It's a very effective technique. Of course, we have some experience with bronchopleural, with lung volume reduction, bronchoscopy with stents, with valves. So the same valves, the one-way valves we use for lung volume reduction approach, the spiration valves and the emphasis valves can be used for blocking a peripheral segmental bronchus, which has a continuous air leak, a persistent air leak. So as I explained before, we first confirm the site of the leak with a balloon, as you see in this central picture. So we inflate the balloon in this segment. We see that the air leak stops. You see here this chest X-ray, chest CT scan. We have a very intense subcutaneous emphysema, and there is a continuous air leak. We block the airway with the balloon. We understand that from this segment there is the air leak, and then we can put this umbrella-shaped spiration valve, which anchors in the airway by these little metal strips here, and blocks the airway, as you see in this picture, and doesn't leave the air to be to flow over this level. At any time, we can remove this spiration valve, and this is one of the major advantages of this technique, that it is removable, and thus, if something bad occurs, if we have a complication like infection or abscess formation or whatever else, or bleeding or whatever it is, we can remove this device from the airways. It is easy and relatively simple to deploy and remove. And this is the other type of valve, the emphasis valve, which is mostly used for emphysema patients for lung volume reduction. But as the spiration one I showed before has some publications, you can see here some of them, where it has been used for persistent air leak and for peripheral bronchopleural fistula closure. So we deploy the valve just as we do for the pulmonary emphysema. Of course, we have first to diagnose where the leak comes from the airway. We block the balloon we block the bronchus with the balloon. And once we know that the leak was from there, we deploy the emphasis valve and the leak stops. And after a few weeks, the patient has healed, and maybe after some time we're able to remove the valve. We have removed valves for this treatment after 1 or 2 months, and the patient has not relapsed. So it is something that it is, again, removable, and you can treat the patient effectively without living inside the valve forever. The simplest and the oldest and the less expensive modality of this group of treatments is, of course, the Watanabe spigots. These are the only devices which are designed for blocking an airway which has persistent air leak. And it's very simple. It's a it can be put by the rigid bronchoscope with a rigid forceps. We grasp the spigot from this area here, from the base of the spigot. It's conical, and then we put it in the airway. It is available in multiple sizes, and it comes it's produced by Novatec. It comes in a little bag with different sizes, and then you choose the size you desire based on the size of the airway, of course, and then you just occlude the airway where the persistent air leak comes from. It's good for, I've treated some patient with these spigots with a lymphoma who was operated, and then he had a persistent leak, and also with fungal infections. It's also very useful, but it needs rigid bronchoscopy, and again, it can be removed when the leak stops and the patient is healed and the lung has healed. Okay, let's move to the second available technique or way of approaching these problems, which is not putting a device to seal, but putting something chemical or biological, a sealant, like a glue or something similar. So bioglue. Bioglue is used by the surgeons mostly. It is useful on the surgical setting, but in bronchoscopy it's problematic because these materials harden when they mix, and sometimes we do not have the time to apply them homogeneously on the fistula, on the orifice of the fistula, and thus this solidifies very early, and then it's expectorated. So uh, it's not very effective, at least in my experience. Any excess material has to be removed, and the scope has to be protected, because sometimes the scope is damaged by this material, which can stuck inside the working channel. We cannot use them for periphery because they cause inflammation. So it's only to seal some small central lesions in the stumps after surgery. This is the application catheter. My experience is not really very good with these materials. I've tried once or twice, but it didn't work, I can say. Another very elaborate idea on producing healing of these problems is to use stem cells. The first publication on stem cell fistula closure was in 2015 in New England Journal of Medicine, and it was a very elaborate study in which these authors transplanted mesenchymal stem cells, which were derived from the bone marrow, and then they were injected in the bronchopleural fistula, thus producing extraluminal proliferation of fibroblasts and development of collagenous matrix and closing of the stump, as you see here. Another more recent approach was taking fat from the abdomen of the patient, and thus centrifuging this fat from the syringe where they were taken from the abdomen of the patient, and creating small syringes of fat which was centrifuged, and thus injecting this material in the orifices of the stent. They call this lipofilling approach. So it's an endoscopic lipofilling approach for the treatment of BPFs after lung resection. They make syringes of 1 ml of this material, of this fat, fat cells from the patient, and then the report says that they have treated 3 to 4 patients. It was a case series with very high effectiveness. I have no experience on that, but I found it interesting. And we know that, in fact, we can find a lot of stem cells. So they take advantage of this presence of the stem cells to introduce this material in the stump, and thus create fibroblastic activity. Another idea which has been recently published is the spraying of recombinant bovine basic fibroblast growth factor. This is a product that it is available in China. I don't know if this is available in India or in other countries. In Europe, I have not found it. But this is an interesting report on local administration of this recombinant bovine fibroblast growth factor, which looks like having a very quick and efficient result on the stump, which heals due to the activity of the fibroblastic growth factor, which stimulates the fibroblasts of the patient and thus creates this healing. It has been used mostly for angiogenesis. Of course, it creates angiogenesis, and it has been widely used for wounds, superficial wounds, external wounds, and ulcers, and it has been found effective for that. I think we need more studies to see if it is safe and effective to use it through the bronchoscope, but there are some publications already in the literature, and I think it deserves more research. It looks very interesting approach. And I will go on the third idea of approaching these lesions. Again, we're talking for small lesions of the central airways, and this is irritating the mucosa to produce healing and healing process and closure by formation of granulation tissue and scar. The first idea, which was there in the literature, was ethanol injection, alcohol injection. That came from Japan and then from Korea 20 years ago and more. Injection with a 21 gauge needle, the conventional TBNA needle in the beginning, and lately with the EBUS needle. This is a recent publication on therapeutic advanced respiratory diseases, which shows again the same idea, which has been revisited. And the authors explain how they can inject with a needle the very small aliquots of ethanol in the borders of the orifice of the stump of the fistula, and this creates an edema in the beginning, and then a scar after a few days, which has been confirmed, and it's very effective to seal the fistula. The same has been tried with ND-YAG laser, of course, and sometimes with electrocautery, but the most efficient way, in my opinion, is to produce a chemical burn with silver nitrate. The silver nitrate salts have, it's known that they have antiseptic and cauterizing properties, and they have recently been used for pleural disease also in humans. Very safe and very effective. This chemical burn is followed by normal healing and scar formation. So we developed this strategy for using silver nitrate. Silver nitrate comes in these little rods, metal rods, and as a material, it has very low melting point and very low solidifying point. So if you approach this metal rod on a flame, then it melts. And what we do is we take a cytology brass we use for our standard bronchoscopy, and we burn the silver nitrate. We put a piece of silver nitrate at the tip of the brass, and then we introduce the brass through the working channel. There is no problem for the bronchoscope because this is not hot. It becomes very solid and cold in few seconds. So it's not burning the scope, or it's not active in the plastic material of the scope. And then we touch as you see here in this video, we touch the area of the stump, of the dehiscence, or of the fistula, of the communication, and this immediately produces this whitening result, this edema, the immediate closure of the communication, and then after a few days, a healing and granulation tissue formation. So several years ago, we published this report. It was the first report on bronchoscopic use of silver nitrate with a flexible scope. There was only one report many years ago in the 80s from surgeons with a rigid scope on silver nitrate application. But I think we were the first to introduce that for flexible bronchoscopy. So we studied the 11 patients, and the median diameter of the fistula was 3 millimeters, but the range was from 2 to 5. We measured the diameter with this forceps. You see the full opening of the forceps is 5 millimeters. So we were able to evaluate the size of the communication. These are some of the pictures of the publication. You see here how the stump was. You can see this little hole here in the first image, and that was the area of the communication. And you see that's the immediate result after the touch of the brass, which is worked with silver nitrate. How this edema and the whitening blancing effect is created, and then after a few weeks, the complete healing. And again, the same result here, the fistula, the blancing effect, the whitening effect, and the closure, and then in other cases as well. So it was a solution for us. We were, at that time, we worked in a very busy center of thoracic surgery. There were several complications after pneumonectomies in different settings, and that helped a lot of patients survive. You can see here in this table of the patients we studied that we had to do several bronchoscopies. This is not usually achieved with one session. Sometimes we used one session, like in this patient here. 2 sessions here. This patient required up to 10 procedures, another 6 procedures. These people 1, 6, 8, 3. You see there are several times that we have to treat the patient. It's not just one time and it's finished. So you have to be patient, and you have to examine all the other options we discussed. But however, this is this pays off because we have a very successful result overall. You can see here some videos of the application. You can see here a small fistula. It's something like 1 or 2 millimeters, but it's enough to create a lot of morbidity to the patient, a lot of problems. Here is the first touch with the brass, which has the silver nitrate on it, and you can see the immediate effect, this blancing effect, the irritation of the mucosa, the chemical burn, and of course we do in every session we do 3 to 4 applications. This is the second application. With just touch, and you see the result. It's immediate. Edema, burn, inflammation. The air leak stops immediately, but the complete result is seen only after a few days or weeks sometimes. Okay. I will end this presentation of the many different modalities by this one, which is the most recent I'm aware of. And this is the use of nested embolization coils, which are designed for embolizing the pulmonary or bronchial vessels when there is bleeding. These are angioplasty catheters, and they can be used through bronchoscopic, of course, observation and application to close bronchopleural fistulas. There are several reports which start from the 90s and all the way up to the 20,000 to 2013. You see, this is from India, and again 2020. So the use of these embolization coils looks promising. The authors say that they can absolutely close these fistulas, especially because these little metal wire has this material on it, which is like hair there, and this produces granuloma, and with this virtue, it closes the fistula completely. So we had, I will close my presentation with this case. It was a very problematic case because it was a young lady who was unlucky enough to have her right lung removed because of lung adenocarcinoma. The problem was that she started with a lobectomy, and then she complicated with pulmonary hemorrhage from the stump. So the surgeon was obliged to go on for completion pneumonectomy. So she underwent pneumonectomy, a very young lady, mother of two children. And then 6 months after surgery, she had recurrent pulmonary infections. She had the change of level in her pleural fluid. And of course, CT detected the bronchopleural fistula. You can see here that there is something wrong with the stump in this area. You see the air fluid level, which is low. And of course, the chest tube was inserted because the patient came to see us because he was flooded from her pleural fluid, which was expectorated all the time. And of course, he had intense cough and very low quality of life. So the surgeon inserted the thoracic tube, and she referred her to us to see what's wrong. So this is the stump of this patient. It's a nice suture, a nice stump. You see there is no um, uh, long stump. It's just a nice surgery, but there is a dehiscence here in the suture line. This is the hole, and there are smaller little holes here. And of course, we treated her with silver nitrate, which is a classical approach in our department for these small fistulas. So this is a brass I was talking to you about. It has some silver nitrate on it. We applied some silver nitrate. We produced this burn, and because she had a bigger opening here, we thought that this would not close with the silver nitrate, so we tried some ethanol injections. You see here the needle. This is a 21 gauge needle of conventional TBNA with which we instill some ethanol in the submucosal area. Take care, ethanol should not split around in the bronchi because it can produce ARDS. And of course, you should not instill ethanol intravenously. So you take care that you have not hit a vessel there. We first suction to see if there is no blood coming back, and then we inject the ethanol strictly submucosally. Please try to be sure about that, because otherwise there might be many and severe complications. So we treat it here with both modalities, silver nitrate and ethanol injection. She went much better. This is a month later, in October 23. The first treatment was in September. Okay, and then next month, October, the air fluid level increases. That means that there is no more flooding of the airways with the pleural fluid. The pleural fluid does not go in the airways. Um, the thoracic tube is still there, but there is no fluid escaping through the trachea, and there is no much air leak from the tube. We did the second treatment. You see here the situation is a little bit better. This is the second application of fistula, of silver nitrate on the fistula. You see this blanketing membrane which is created. And again, we injected ethanol, and you see here a much better result. The second time was even much more effective there. So here is ethanol injection again and silver nitrate on it, and we were very confident that this treatment went even better. So the level increased even more. There is no air escaping to the thoracic drain. Symptoms have ceased, and the patient was pretty good. Her level of quality of life had increased. You see here the third bronchoscopy, November 23. A month later, the scar is evident here, and the little fistula here is closed, and that we did the third treatment with silver nitrate. You see here that in that case, we didn't apply ethanol. We just did silver nitrate for preventive reasons. So we wanted to be sure that she will do well and that she will not relapse. And that was on November. The procedure was very successful. The lady went back home, and the CT of the January 24 shows complete resolution of the tracheal fistula. She has no more complication. The hemithorax is full again with this pleural fluid, which is normal. The thoracic tube is removed, and the lady is happy with her treatment. Okay, and everyone is happy. But 2 months later, she comes back again because she had a very intense respiratory tract infection and she relapsed. She felt that the bronchopleural fistula reopened and she had again cough, she had again purulent secretion, she had again fluid coming out of her trachea. And of course, the surgeon reinserted again a thoracic tube to evacuate the cavity and protect the patient. She was on antibiotics. We did the chest CT. You can see here very nicely this tunnel of the communication from the trachea to the pleural space. And the lady was, of course, desperate and very anxious about this story. She thought that she had gone over with this problem, and now the problem comes back again. And of course, is referred again to our department. What to do? We tried again, Nestor. We tried again some silver nitrate, but we realized that because the communication was not superficial, but it was the whole tunnel, it was very thick. The way of communication was like a little path, a little tunnel between the bronchial airspace and the pleural space, and thus the silver nitrate could not treat that because the silver nitrate is a very superficial mucosal healing produces. The problem is that she had to do something with a tunnel which connected the bronchial space with the pleural space. So we thought that we could use these angioplasty catheters, and we introduced one, Nestor embolization coil. You see the coil here. This is the coil deployment system. This is a little hole here of the bronchopleural fistula, the relapse one. And you see how we introduced that in the hole, through the hole, to the pleural space. The idea was to deploy half of it in the pleural space and half of it in the bronchial space. Thus making like a sandwich, something. So half of the coil is in the pleura, half of the coil in the bronchi, and then just to be sure, we apply some silver nitrate on the surface as well. This is what remains in the bronchial space of the patient. With this treatment, the patient went perfectly well. You can see here the coil. You see a part of it in the bronchus, and most of the coil is deployed here in the pleural space. This here is chest X-ray just before removing the catheter, the tube from the chest. And of course, she is perfectly well, and clinically she is very good. And I hope that she will remain so because she has underwent through many problems all this year. So this is a good example of combination of different modalities, silver nitrate, alcohol injection, and thus, and also embolization coil. And as my mentor, Mark Noppen, was saying in one of his very nice publications on bronchopleural fistulas back in 2005, 20 years ago, he wrote that there are no established guidelines in the proper management of patients with BPF, or even a consensus on how to approach this problem. Which is the role of the techniques and the patient selection for endoscopic procedure? Which combination of procedures is best for each individual case remains yet unanswered methodologically. However, my belief and my experience says that it looks like no bronchoscopic technique is universally applicable in all cases. So no technique is, no sole technique is enough to treat these cases, and treatment should be individualized, taking in consideration all the specific circumstances of each patient. So we should choose very well the patient in whom we should apply technique, one of these available techniques I presented in this presentation. And of course, we should be very cautious and very extensive in the study of this patient before we decide a specific management. This is our unit in Athens. It's a very busy unit with the bronchoscopic modalities of all kinds. And we have invested a lot in training other colleagues with digital and anatomical models. And we're part of the ERS web for training and accreditation for EBAS and other techniques. So we are very glad to receive people from abroad, and we're always open and at your disposal should you need any help in training or achieving some skills in several modalities. Thank you for the invitation. Thank you for your attention.
Thank you, Professor, and can stop sharing. So now we have Q&A session. I selected a few questions, not to take up all the questions. So, in the last case you showed, there was one question from the audience saying, why was the surgery not performed again? And to close the suture, why a bronchoscopic technique was used?
Yes, the surgeon had done 3 surgeries to this patient. He had gone first to do the lobectomy, then next day she bled, so he had to do completion thoracotomy, completion pneumonectomy, and then when the fistula first appeared, he tried to close with a buttressed omental flap, and then the patient relapsed. So if he would go again, that would be the 4th thoracotomy, and both him and here the patient wanted to avoid.
And a few questions about silver nitrate, Professor. Do you have like a size criteria, like as I think you said, between 1 to 3 mm is an ideal choice, right? To use silver nitrate in.
Exactly.
Yes.
Our limit was 5 millimeters. That's why I showed you this forceps, which in full opening is 5 millimeters. So that was a measurement we did to be sure that we can apply silver nitrate. If the opening, the visible opening, exceeded this kind of size, then we were about to think in some other modality of those I presented. Silver nitrate is for superficial and for small fistulas, up to 5 millimeters.
One more question is coming. It's like in your series of 11 patients whom you treated, all these patients are post surgical BPFs.
Right.
Any experience on like application of silver nitrate in benign disorders?
As I explained, I think silver nitrate is for central airways, is not for periphery. So we cannot use it for peripheral air leak, for persistent air leak. And central leaks due to benign disorders is very rare. Um, Mostly the benign disorders have a peripheral leak, and it's either because of tuberculosis or abscess formations or fungal infection in the periphery of the lung. And in that case, we mostly use either spigot, Watame spigots or valves or other plugs that we can close the fistula with.
And what are the tissue changes that you see after silver nitrate application, immediate and late? And what is the frequency of surveillance bronchoscopy we should
Mm.
perform? What is your advice on doing a repeat surveillance? How many days after the procedure?
Okay. The moment we touch the mucosa with this brush, which has some silver nitrate on it, we see immediately we see a blanching effect as it is described in the literature that is whitening. We see the mucosa turning white. And this is the reaction of the mucosa to the chemical burn. So we see whitening of the mucosa, and a few moments later, we see edema. So it's edematous, it's swollen. And this edema closes the communication most of the times immediately. So even if we have some air leak in the tube, the thoracic tube, we see this stopping. And we know that this is not a permanent effect yet, but we know that the treatment was effective and that that will irritate the mucosa and initiate the healing process. So a few weeks later, we wait for healing to start. And so the next bronchoscopy will be scheduled in 10 days. So 10 days after the initial bronchoscopy, we examine the patient to see the level of healing we achieved. And thus, if this is not really successful, we repeat the silver nitrate application. And then again, after 10 days, we see. If we finalize the treatment saying that, okay, it was effective, then we see the patient after 3 months.
Thank you. And the last question, the same type of small fistulas that we see across our tracheoesophageal communications, very small communications. Even in my center, after seeing your paper, we did one application. What do you have any experience on tracheoesophageal fistula closures? And can we do this for especially those pediatric, very small kids they present with the TEF? Any
Uh,
experience?
I have no personal experience on that. I have not used silver nitrate on tracheoesophageal fistulas. And as far as I'm aware, I have not seen some publications on that. I think tracheoesophageal fistula is another story. It's a different pathogenesis behind. Um, uh, uh, Most of the times, the tracheobronchial fistulas I see are either due to iatrogenic rupture of the membranous part of the trachea during intubation or after prolonged intubation with a very inflated cuff or due to esophageal cancer or radiation of the mediastinum. That are the main causes of tracheobronchial fistula I'm aware of and I see in my practice. And in this case, I think that standing is more effective than healing modalities. And one reason for that might be that there is a lot of acidic environment in the area of the esophagus and in the fistula. So these treatments, I'm not sure that they would be useful or effective there. It's a completely different chapter.
So with that, we end the questions. And once again, thank you for your
Thank you.
elaborate discussion because I think we went a long, you discussed a lot on all the aspects of BPF closure through bronchoscopy. And once again, from Yashoda Hospitals and Academy of Bronchoscopy, thank you for this accepting our invitation. And for the next session, we have a very interesting session for fellows in the month of May. So we are discussing on complex issues where we have problems in making a decision, like in complex cases where you don't have a clear decision making. So fellows will present a few cases where the decision is not clear, and we have some expert panelists coming, and then they will help us how to make the decision in such cases. Thank you once again,
Thank you very
and
much, Harry. And
thank you.
congratulations for this very nice effort. Thank you very much. Goodbye.
Thank you.